Hello, everyone. Today we have another lecture of Principles of Surgery course, and I'm happy to introduce to our today's speaker, Dr. Kenney, former chief of Brigham and Women's Faulkner Hospital, and a teacher and mentor of residents and faculty at Brigham and Women's Hospital, who will give us a talk on surgical bailouts. Thank you very much, Dr. Kenney, for joining us today. We're so happy to hear your presentation.
Well, thank you, Ali, and I'm sorry to those of you online for the delay. We had a little bit of a, as they call it, a bandwidth problem, I guess. I can't see your faces now just because of the way this is set up. So if you do have a question in the middle of all this, please raise your hand and Ali will transmit it to me. I wanted to make sure at the beginning that everybody knew what I was talking about, and by the term bailout, it's, I suspect, not a uniquely American term, but at least in terms of definitions, you could also title this talk, How to Get Yourself Out of Trouble When You Don't Know That You're Getting Into Trouble in the First Place. So the definitions I would use are really two of them. The first is that you come upon an event or an unexpected finding during an operation that forces termination of the procedure. In other words, you have to back out without accomplishing the primary objective of the operation in the first place. Or an event or unexpected finding that requires a change, a significant change in the operative plan. Something that might stop you from doing it the way you always would do it. You might change what you're doing, you might have to do more, you might have to do less, but something like that happens intraoperatively. So you have to be prepared for one of these eventualities to arise. It's not common, particularly when you've got good preoperative imaging and you know what you're going after, but it does sometimes happen. This is a series of cases, and I'm going to ask what are probably just rhetorical questions for you, but particularly for those of you who've been at this for a while, some of these may be somewhat familiar. So we'll start off with the first case. There's an 82-year-old man. He's pretty angry, doesn't want to be there. A rupture or a big lump in his groin. He's had intermittent medical care, but he does have known treated hypertension, occasional wheezing. He has a 50-pack year smoking history, and he has type 2 diabetes. About a year ago, he was convinced to undergo a colonoscopy. He didn't really want to have it, but the procedure was aborted because the endoscopist could not get his scope through the sigmoid colon. And while he was doing it, he thought he saw a light in the patient's scrotum. Now, the patient hasn't had any prior surgery, and the major finding on physical exam is a massive left scrotal hernia, at least 12 inches in diameter. Now, you're going to take this patient to the operating room. What anesthesia would you choose or request? Could you do this under local with sedation? Probably not. Could you do it under spinal? Maybe, but you're going to have to get this hernia reduced, and it doesn't reduce in the office. Most people would say, I need a general anesthetic with a full endotracheal intubation, muscle relaxation, etc. What antibiotics would I choose? Would I use standard antibiotics just to cover the skin bacteria that I might encounter even after a prep? Or would I give him something more just in case I got into the bowel? Probably would want to give him something more just as a preventive. So something like cefazolin and metronidazole, for example, would be a combination that might make sense. What incision would you choose? Most of us would start out with a standard left inguinal incision like you would do for any hernia. Although some might try this laparoscopically for a hernia this large, probably isn't going to be successful. So here's the problem. After opening and making your incision and you get around the spermatic cord, you open the indirect sac because it's too large to push it all back in again, and you find 2 feet of sigmoid colon and a large amount of momentum in the hernia. Comes up into the wound quite nicely, but it won't go back into the peritoneal cavity. There is, in fact, a sliding component where a portion of the hernia wall itself is a piece of the sigmoid. How do we get back in? Well, you can push like hell. He's got muscle relaxation, but it still won't go in. We can put him in a steep Ellenberg position, head down, make sure the anesthesiologist has given him enough relaxant, and then keep pushing. It still doesn't work. Now what? There you are. You've got an open incision. You haven't fixed the hernia yet because you can't reduce it. Well, the answer, the bailout, is to perform what's called the LaRocque maneuver, which is an old name, but basically consists of making a counter incision about 2 to 3 inches above your initial incision. And you actually go into the abdominal cavity. You actually open the abdomen through an oblique incision. You get your hand in, and now, obviously, by pulling and still pushing, you can get that colon probably reduced back up into the abdominal cavity. Then you can proceed with the operation, removing the hernia sac as much as possible, closing it, and then putting in some type of mesh in standard fashion. I'm not going to go into that today, but this is the kind of thing that, you know, you have to know how to do. Is it very commonly needed? No. But it's a rare procedure. I did one about 3 years ago with one of the residents here, and she'd never seen it. So it's uncommonly necessary, but it is a bailout. It's a way to get around the problem where it looks like you can't reduce a standard inguinal hernia. Not very common problem. Okay, case 2. You're called as an emergency down to the emergency room to evaluate a 19-year-old man who was involved in a motorcycle accident. He was wearing a helmet. He's awake and he seems to be mentating. He seems to be able to answer questions. His airway is intact. He's breathing with equal bilateral breath sounds. There's no sign of any kind of chest wall injury. However, his blood pressure is 80/40. His pulse is 140. Respirations are 28. There's an obvious splinted left femur fracture, which was closed. His abdomen is massively distended and quite tense. Now what? Do you take him to the operating room? Do you take him to the CAT scanner? Do you perform an ultrasound examination in the ER quickly? I think if anything, you could either do one of the first thing or the third thing. I wouldn't let this guy go to the CAT scanner because I'd be very worried that he has major intra-abdominal bleeding. If you wanted to do a quick focused abdominal sonographic examination to see if your suspicions are confirmed, you could do that in the ER only while waiting for the operating room to get better, to get ready. What would you order? Well, we would probably order a massive transfusion protocol to be ready because we know he's lost a lot of blood already into the leg from that fracture. And it's likely that this massive abdominal distension and hypotension is related to more blood loss. Will we do anything else in the emergency room? Not much. Not much. We've got some big IVs in them ready to give him large amounts of blood. We would certainly make sure that he is typed and screened. But this is the kind of patient who may need even O-negative blood. At that point, our next move is to go to the operating room. He gets a lot of resuscitation. He gets crystalloid. He gets 2 units of O-negative blood. When he is anesthetized, his blood pressure drops to 60, palpable, on induction of anesthesia. So we're going to make a very long midline incision from the sternal notch down to the pubis, and we're going to assess for bleeding. And I'm sure some of you have done this already. We're going to pack all 4 quadrants. We're going to allow anesthesia to sort of catch up, hopefully to warm him up, give him more fluid, give him blood, give him platelets, give him fresh frozen plasma, and then sequentially remove the packs to figure out where the blood's coming from. In this case, we find massive bleeding from the right upper quadrant. There's a small pelvic hematoma that's contained, and the rest of his abdomen looks okay. So it looks like the bleeding source is in and around the liver. At this point, anesthesia has started processes. He's getting a massive transfusion protocol with ratios of 1 to 1 to 1 of packed cells and platelets and fresh frozen plasma. But even with all that, his blood pressure is 70/30. pulse is 160. Examination shows a large fracture in the right hepatic lobe with active bleeding. What are you going to do now? Well, the first thing you want to do is what's called a Pringle maneuver. And again, I suspect many of you have tried this before. You get your fingers, or better, a clamp, a rubber shod clamp across the porta hepatis. So that means you're clamping the hepatic artery, the common bile duct, and the portal vein, thus stopping all inflow into the liver. You're hoping that that'll stop the bleeding. And in many cases it will, and gives you a chance for anesthesia to catch up and begin to start to look for some of the bleeding sources in the fractured liver. But what if it doesn't stop? What are you worried about at that point? You've done your Pringle, you've stopped all vascular inflow to the liver, and yet there's still this dark venous blood oozing up from over the top of the liver. The likely injury here is hepatic vein avulsion off of the vena cava. The patient now has 10 units of blood and more coming. He's gotten all the right platelets, but his temperature is now 33 degrees. He's getting cold. What do we do? Can we control the bleeding with some type of intravena caval shunt, which was popularized in the 1970s and 1980s? Or do we bail out? Do we pack the area thoroughly? Try to control the bleeding with packing, and many times you can. And then actually close the abdomen temporarily, get control of his coagulation parameters, warm him up, take him to the intensive care unit, reverse the acidosis, reverse the coagulopathy, and then when everything's available, you've got help, you have an experienced hepatobiliary surgeon with you, hopefully, you can go back to the operating room and carefully try to repair this injury. Now, I say that in full recognition of the fact that this particular injury, in the United States at least, has a mortality rate that's probably more than 98%, even with all this. So this is a very, very lethal injury. But if the patient's going to have any chance at all of surviving it, he needs to be, at least physiologically, in reasonable shape with his coagulation parameters corrected, his temperature corrected, and with appropriate help. So that's the bailout here. For a hepatic vein injury, you stop, you pack, you get the patient in better shape, and then bring the patient back to the operating room at some point in the next 12 to 24 hours. Okay, here's another one. 65-year-old man comes into the medical service. He's had an upper GI bleed. His history is that he vomited bright red blood at home. He has hypertension and a very distant history of a coronary artery bypass graft, and has a moderate alcohol history. You don't quite know what that means, but it's better than nothing, I suppose. The key part of his history is that he underwent an open aortofemoral aneurysm repair 15 years earlier. So he has an incision in the midline and 2 groin incisions. So he's had a giant graft placed. He has otherwise had no abdominal surgery. His laboratory numbers aren't that bad. His hematocrit is 36. He has normal electrolytes, coagulation parameters are normal, kidney function is normal. In the emergency room, he underwent upper endoscopy on an urgent basis. All they saw was blood clot, and they wanted to repeat it in 12 to 24 hours because he's stable right now. And indeed, he's stable overnight. The next day, he goes back to endoscopy, and now they've got the clots out of the way. They can see better. They don't see any active bleeding at this point, but they see a curious finding in the 4th portion of the duodenum. They describe it as whitish material seen in the posterior wall. If you're a surgeon and you look at this, you say, you know what this guy has? He has an aortoduodenal fistula. The suture line where the aorta and the vascular graft are connected has now eroded into the duodenum, by definition has become infected, and that bleed he had the previous day was a herald bleed to tell you that badness was down there and something was going to happen that was very bad. And there's a couple of scenarios here. If the patient is stable, you can plan to go to the operating room. And the first thing you have to do is an extra anatomical bypass where you do an axillofemoral graft to reestablish flow to the lower extremities. That allows you to then go into the abdomen, divide the fistula, free off the duodenum, clamp and oversew the aorta, and take out the vascular graft. And then you have to fix the duodenum with some type of bowel repair. But in this particular case, he vomits bright red blood again, and now his blood pressure is 90/50, and his pulse is 120, and he's bleeding. Now you don't have the luxury of time. You have to get this patient to the operating room. And now it gets more complicated because the first thing you have to do is stop the hemorrhage. And that means you have to get into the abdomen, and now he's got two pressors running. Blood has been typed and cross-matched. Blood is in his nasogastric tube, bright red blood, so it's refluxing back up into his stomach. We prep and drape him first. We get him ready to be operated on so we can do a rapid sequence induction of anesthesia. The reason why, of course, is that you put him to sleep and he's hypotensive, his blood pressure is going to go down even further, just like the previous case. You get into the abdomen, there's some adhesions, some inflammation around the duodenum that's densely adherent to the previous graft. Can I bail out of this one? Now what do? I'm already there. Well, what I have to do in sequence, I have to get control above and below the graft. I have to then detach the duodenum in some kind of temporary closure of the duodenum to prevent leakage. I have to take out the old vascular graft. Then I have to close the abdomen temporarily. I got to do vascular bypass to get blood flow back into his lower extremities. And then I got to go back into the abdomen, freshly prepped and draped, and fix the duodenal injury. A very viable alternative, if it's available, is endovascular approaches to all this. An endovascular approach, putting in a graft, may buy time as a bridge to get to an open pair. That way you can hopefully get the bleeding under control. You can then do the extra anatomical bypass and not contaminate that with another procedure in the abdomen. There is certainly data that suggests this is a better way to go overall. I'm not a vascular surgeon, and I would certainly refer this case to a vascular surgeon if I had the choice. But this is the kind of thing where you need to have a backup plan so that you can bail out and change your operative strategy as the need arises. Okay, case 4. This one up front seems this 25-year-old woman comes to the emergency room, a 4-day history of increasing right lower quadrant pain and a very poor appetite. The pain began around her umbilicus and then migrated to her right lower quadrant. So with history, you're already thinking of appendicitis. Seems pretty obvious. She's otherwise healthy. She's had 2 children. She had no prior surgery. Her last menstrual period was about 2 weeks earlier. So she's probably got appendicitis. But anyway, they got a CAT scan, which they do in the United States for anything. It's a CAT scan. And she's diagnosed with appendicitis. CAT scan shows a large phlegmon edema swelling around the appendix with localized and contained air bubbles. Now, she doesn't want to get it out. They want to just be done with it, or they want an operation. In the United States today, someone like this might be treated expectantly with just antibiotics. And there is data that suggests for some patients like this, that may be sufficient treatment to buy you time. And that's about in and of itself. But in this case, because she does have some evidence of an abscess with the bubbles, because they're pushing you, you decide to go to the operating room. Your antibiotic coverage must include both aerobic and anaerobic gram-negative coverage because you're dealing with the colon here. So with appropriate coverage, if we do it laparoscopically, we can certainly start that way. Sometimes you can get away with it. Sometimes you can't. On examination, her ovaries and her uterus appear normal. There's a large immobile phlegmon, big edematous swollen mass in the right lower quadrant, to which several loops of bowel are densely adherent. It cannot be dissected free laparoscopically. So now you have to decide, do I open the abdomen and go after this thing, which commits me maybe to resecting her ileum and part of her cecum? Do I back out and treat with antibiotics alone? Tough call. Tough decision. First of all, if you did make an incision, how would you do it? The last time I met with you, we talked about different types of abdominal incisions, one of which for appendicitis, of course, is a standard McBurney. But something like this is going to require probably open midline lower abdominal incision because you need better exposure than the McBurney alone can give you. And even after open manipulation and dissection, the small bowel really can't be safely dissected free. You decide this is the case after there's at least one enterotomy. Now what? Should we just fix the hole in the small bowel and get out? Or should we do a limited ileocecal resection? This is a tough decision. There's no direct correct answer. I think in most people practice in the United States, we would go ahead and resect the ileocecal area, do a primary anastomosis between the ileum and the ascending colon, and be done with it. But you're also kind of regretting the idea that you operated on her in the first place, and maybe she could have been treated with antibiotics. These are all a little different, and that's one of the answers with this case, unfortunately. Now, here's some variations, which many of you may have seen. Let's say instead of this large phlegmon and appendiceal mass, instead you discover that she has a large right ovarian cyst that appears hemorrhagic. The appendix is normal. Should you convert to the open operation and try to take it out, the cyst, or should you leave it alone? If it's that large, the cyst excision is probably okay if the ovary can be preserved. Remember, she's only 25 years old, and you don't want to take a chance of rupturing the cyst. Obviously, if a gynecologist is available, which isn't always the case, you should get some help. It's a tough call. I think for many of us in the United States, if we saw a normal appendix and an ovarian cyst, we might just back out in a woman this age and let her go to the gynecologist and see what he or she would say. If all it is at is laparoscopy, if it's open and you think you can do it safely without compromising the ovary itself, you probably should take it out. Now, if I change the age of the patient and I make her 65 and not 25, the decision-making is a lot easier because the ovary certainly can be resected, and most general surgeons have the capability of doing that themselves. They don't need a gynecologist to help them necessarily. So that's the first variation. Here's the second variation. Same presentation, big phlegmon on the right lower quadrant on CAT scan, same pain pattern. And at laparoscopy, there's this dense phlegmon. We open the abdomen. The small bowel loops can be separated from each other, and they're non-perforated. But the loops themselves are diffusely thickened. They're red, they're erythematous, with creeping fat coming around from the mesentery. The appendix looks like it's normal. The cecum is erythematous, inflamed. The likely diagnosis here, as most of you know, is renal enteritis or Crohn's disease. The management is to back out, is to bail out, get out of the abdomen. There's nothing more you can or should do here. Resist the tendency to try to biopsy anything. It's not going to provide any useful information and could lead to a fistula. And importantly, leave the appendix behind. Because if you take it out, that erythematous cecum, you don't know that the cecum isn't involved with the Crohn's disease. And in that setting, taking out the appendix could lead eventually to a fistula. So most of us would say, if you found Crohn's disease at surgery, you back out, let the patient be treated medically. Now here's the third variation. At exploration, laparoscopic or open, classic appendicitis is found and you take it out. Congratulations, you did it. But you decided that you want to run or look at the last 2 to 3 feet of ileum, which you should always do anyway, specifically for this complication, or finding, I should say. During subsequent routine examination of the small bowel, a 2-inch long, non-inflamed structure is found about 2 feet proximal to the ileocecal valve. It comes off of the anti-mesenteric border of the bowel, and as most of you know, I suspect it is a Meckel's diverticulum. What are you going to do about that? And should the management of that differ by age? This is an asymptomatic Meckel's diverticulum in a 25-year-old patient. People go around on this all the time. The thought being, well, it's asymptomatic. Why should you take it out? Because you could. It's easy enough to do. But you have a suture line, you have a fresh anastomosis perhaps, and you say, well, she's got 40 or 50 years of life left. We don't want her to get in trouble with this thing. This is an algorithm that came out of UpToDate where you identify incidentally a Meckel's diverticulum in an otherwise asymptomatic patient. I'll go through it with you. If the patient's 50 years of age or older, and if there is a palpable abnormality in the Meckel's, you probably should just take it out. And we'll talk about what the resection is in a second. On the other hand, if no palpable abnormality, there's nothing wrong, you don't feel any abnormality suggestive of aberrant gastric or pancreatic tissue, leave it alone. She's had it a long time, it hasn't bothered her. Now, if she's younger than 50 and is in fact a child, the argument is go ahead and take it out because yes, the likelihood of getting into trouble with this over time is high, and we don't want that to happen since we have the opportunity to remove the Meckel's. If the patient is an adult, as our case here, between 18 and 50, let's say, if it's bigger than and longer than 2 centimeters, if there's an associated fibrous band that might produce obstruction down the road, if there's a palpable abnormality, all of those things suggest taking it out. Male gender also suggested because complications from Meckel's are higher in male patients. And on the other hand, if it's a female and none of these things apply, you leave it alone. All of these decisions basically can be made and differentiated in the operating. Sometimes you just say, it doesn't look right, I should take it out. Taking it out does not mean just sticking there across the base and leaving it, which you can do, but it may not be appropriate for the patient because sometimes if there is abnormal mucosa, it can actually spread down on the inside of the ileum. So the right resection here is to actually do a formal bowel resection, which includes the Meckel's and an anastomosis. Seems aggressive, I know, but it guarantees that you will get all of the abnormal mucosa, if there is any, and the Meckel's will be gone. But this algorithm is useful to keep in mind. All right, case 5. A 67-year-old woman is undergoing elective repair of a recurrent incisional hernia. Primary surgery was a hysterectomy many years ago. She has hypertension, she has coronary artery disease, and she has a 60-pack year smoking history. Now, right there, many surgeons would say, nope, stop it, not going to touch her, as long as she's smoking, because the risk of recurrence is so high with patients who are still smoking. Unless she's profoundly symptomatic or has some other, obstructive disease, I'm not going to operate on her. Well, this particular surgeon said, well, she's having pain, she's symptomatic, I'm going to try again. This is the 5th time someone's tried to fix this hernia. And she's had multiple pieces of mesh already inserted. That's what you're dealing with up front. But yet she has yet another recurrent hernia. And on CT scanning, a large amount of small bowel is up in the sac. So the surgeon starts out laparoscopically, but rapidly abandons that idea because of adhesions. You know, she can't see where she's going. She decides she's got to convert to the midline incision. So she opens the abdomen carefully, because even despite that care and all the adhesions, they make a small enterotomy and a large amount of intestinal content spill into the wound. So just to reiterate, we've got a patient with multiple prior incisions, multiple prior insertions of mesh, who now has contaminated abdomen. Now what do? How can we get out of this mess? What are we going to do? Well, we have to fix the hole in the bowel, obviously, and that might even require a bowel resection. So that's the first question to ask and the first thing to consider. Once we fix that, what kind of permanent repair can be offered? By definition, we have a contaminated field. We've had bowel content spill into the wound. Do we have to worry about the old mesh getting infected? Arguments go both ways on this. Some people say, well, the mesh has been there a long time. There's been capillary ingrowth. Antibiotics may protect her. They may not, unfortunately. So some would argue we should just take out all the old mesh. This is getting into a big operation. Now we've got an enormous hole. How can we fix that? Well, guess what? More mesh. But now you're putting mesh in the face of active infection, or active contamination, I should say. It's not an infection yet. It's not an easy case. Many people would choose some type of biologic mesh, stratus. There's another one called phasic, which is extraordinarily expensive in the United States. But these may be protective in these settings where there is active infection at the time. You could also try to buy time with some kind of temporary closure, but you've got a fresh anastomosis there. The risk of leakage from that is going to be high. So the bailout is to get the old mesh out. But while you're trying to think about this, the bowel beginning to look a little odd too. Oh my goodness, the bowel looks ischemic right where I did my anastomosis. Now what? How do I assess the viability? Well, there are several ways you can do that. You can look at it for one thing. You can warm it up with some warm towels soaked in warm saline. You can get a Doppler with an ultrasound and see if you hear pulsations in the mesentery. You can inject fluorescein dye with ultraviolet imaging, or more now in newer time, the indocyanine green, but that takes about a half an hour to light up. Those are ways to assess viability. But if the bowel looks purple and black, you got to remove it. Now what? Should you put it back together again and risk yet another episode of ischemia? Or should you do a temporary stoma? This is getting pretty complicated, and we haven't even fixed the hernia yet. There's probably no right answer here because you have to deal with what you're looking at. Most of us would probably end up doing a stoma at this point with a temporary abdominal closure, get the patient over the acute event, and then bring her back and try to fix the hernia and fix the bowel in a subsequent operation. It's going to vary a lot depending upon how the patient is doing. If they're very stable and young, and this patient is not, it might be an option to do more right then and there rather than bring her back a second time. So each of these is going to require separate kind of decision making. And here's one I hope you'll never see. A previously healthy 57-year-old woman is undergoing an open elective low anterior resection for a very high rectal cancer. So the plan is to remove this and do a primary anastomosis. And the section's going fine. We've gotten into the retrocolic space laterally on the left side. We found the ureter, it's fine. But as a surgeon is putting his or her hand down, suddenly a large amount of dark venous blood starts to well up in the space that you've been dissecting. What do I do now? I've got major bleeding. Patient's getting hypotensive. 2 units of blood are brought to the room and started. Blood pressure is dropping. You pack it. You stop it for the time being. You hold it, and then they can catch up, and then they can get the blood pressure back. But with two suctions working, finally, you got two suction devices in there, you see that you have created a tear in left common iliac vein from all the third section. Blood loss at this point thought to be about 4 units of blood. And a vascular surgeon can burn about half an hour. Packing can mostly control the bleeding, but now what? Do you wait for the vascular surgeon? Certainly not an unreasonable thing to do if you're uncomfortable sewing blood vessels. But you might ask for this device, which is called a Satinsky clamp. And as you can see, it has kind of an angle to it like this, but you might be able to get it onto the vein or clamp the vein entirely and isolate the area of the tear so you can fix it with some 6 or 7-0 proline if you feel comfortable doing that. Many surgeons don't. So the next step, and a quick one, and this is good for any situation where the vein like that has been injured, is something we all have available, and that's the ubiquitous Foley catheter. You get 2 of them, one distally and one proximally, and inflate the balloon. This is through the tear, through the hole itself. Inflate the balloon, and that will stop the bleeding temporarily and give you the time it takes to get a surgeon there who can fix it, or perhaps you can try it yourself. But this catheter is certainly available, and you don't need any special training to use it. And you can put it in, inflate the balloon, and you can stop the. So those are my cases. I deliberately left some time here. That's the end. I deliberately left some time, and I'm going to stop sharing now, Ali, if you're there, and we can open it up to questions.
Thank you very much, Dr. Kenney. And we have a first question from Markian, please.
Good evening. Thank you for the lecture. I have 2 questions. First, about the first case with the inguinal hernia. In the case, if we reduce the hernia into the abdomen and the patient starts intraoperatively to have a compartment syndrome, do you have any advice for bailout procedures there?
Well, sure. If it's severe, you may have to actually open the abdomen and decompress them and put some kind of temporary closure in. I got to tell you, Mark, and I've not seen that happen. The more common issue, well, you could. I mean, if the patient has that much out and if his abdomen is that small, there is a concept called loss of domain. In other words, so much of the bowel has been outside for so long that if you push it back in again, they start having respiratory, pulmonary complications as well. Yeah, in that case, you might have to open and put some kind of temporary closure in, as crazy as that sounds. I've not seen that happen, except I had one patient many, many years ago, I think it was a resident 40 years ago, where not only the sigmoid colon, but about a half of the patient's small bowel was in the scrotum. He had the hernia a long time. And we actually started doing some sort of weekly insufflations of gas into his abdomen to expand slowly his abdomen so that it would accommodate the bowel, and we eventually got it back in again. I think he had to have a counter incision too, as I remember, but it's been many years. But it's a good question. I think if you really forced enough in there and you had a compartment, the first thing you do is take it back out again, and relieve the compartment syndrome, and then maybe try to expand the abdomen somewhat, some kind of temporary closure. I would think that would be rare, but it's certainly possible.
And is it possible to use a REBOA for the patient in the third case with the aortoduodenal fistula?
Yes, absolutely. I should have put that in the slide. That would come under the heading of endovascular, but a REBOA would be one way to try to control it. Hopefully you're not going to, if you make that diagnosis, hopefully you're going to get the patient to the operating room before they start to massively bleed. And you can do the extra anatomical bypass first. So that's in place, and then you do the abdominal surgery. The way I gave it to you, yes, the REBOA, for those of you who don't know what that is, it stands for resuscitative endovascular balloon occlusion of the aorta. So that if you have massive hemorrhage from trauma, which is where it's normally used, you can put this up, and it's like doing a thoracotomy and clamping the aorta in the chest. It's the same principle, only you're doing from the inside, and you close off the aortic inflow. And there has been a lot in the trauma literature about doing that. But your question is good. I mean, you could certainly try to do it in the same fashion.
Thank you.
Thank you. We have another question in the chat. So why we should do surgical resection of macula diverticulum to male patient? What about female patients? Is it associated with oncology process?
I don't think it's associated with the oncology process, but the data suggests that complications from MECLs in males are 2 to 3 times as frequent in males as they are in females. So that's one of the reasons why you would lean toward removing it if you had a good reason to do so in a male patient. I don't think it's got to do with oncology. I'm not aware of oncologic changes in the MECLs.
Mm-hmm. Thanks. Next question, Dr. El Kafarna, please.
Thank you for the great lecture. I had a case, a 30 years old patient who had a big avulsion of the lower abdomen with complete dissection of the right iliac vessels. And well, he was clinically dead, but the anesthesiologist managed to revive him, and we had to deal with the hemorrhage. So we did a crash laparotomy, and we dissected, ligated both vessels, the artery and the vein of the right iliac artery and vein. But the bleeding didn't stop there. So upon further inspection, we found that there is a laceration at the level of bifurcation of the inferior IVC and the aorta. Well, we didn't have a vascular surgeon. What we did is, as you mentioned, we inserted a Foley catheter through the right iliac artery, and also we inserted 2 Foley catheters in the IVC. How long, my question is, how long can we keep the Foley catheter, and should we do a bilateral fasciotomy of the lower extremities?
How old is the patient, Hassan?
30.
30-year-old and non-smoker, obese or not?
No.
No. Well, obviously, a cold ischemic time, warm ischemic time of the lower extremities is a significant issue. You know, I guess it depends on what your plan is. If you're going to have to wait a long time to get a vascular surgeon to help you, or even transfer the patient to another hospital, then
We wanted
yes,
to transfer.
I'm sorry?
Sorry, we were planning to transfer the patient to another facility, which was like 30 minutes. But before that, we had to stop the bleeding.
But you did stop the bleeding with these Foleys, is what you're telling me.
Yes.
Right?
Yeah.
I missed what you said. What was the primary injury? Was it a gunshot wound, or what was the injury?
A blast injury.
Blast injury. All right. I guess I would probably do a fasciotomy. Yeah. I mean, because by the time the patient gets to the other place, you know, there's going to be significant swelling. There's going to be significant reflow issues. But then you have to balance that against the time it's going to take you to do the fasciotomy. And where are you going to do it? You're going to do it down just in the calves. You're going to do it in the upper legs, probably in the calf. You know, there's no easy answer, but I think I would be considering it if I had been in the operating room a long time already with the vascular outflow compromise, which it sounds like you probably were. You're already a couple of hours into this where the blood supply to the lower extremities has been compromised. I think the fasciotomy, the sooner it's done, the better. So I guess it becomes an issue. What do you do first? Do you transfer the patient to the other hospital, or do you get your fasciotomy done and then transfer him? I probably would do it that way. But other surgeons might vary with that opinion.
Thank you very much. Next question from Sofia Lisecka, please.
Good evening. Thank you so much for interesting cases. And I want to ask you about if you had a patient with a stab injury into the abdomen, and we do a laparotomy, see a spillage from the colon, and just suspected the retrohepatic injury. Can we do just packing the hepatic and wait for help, or can we do something else?
So, Sophia, I'm a little confused. The colon was injured as well, or just the retrohepatic cava?
Some oozing from the surface of HEPA, and we just suspected the retrohepatic injury.
Yeah.
but we can see it. We just see dark blood behind the
Right.
liver.
Yeah, to get to that, it's hard. You have to mobilize the right lobe. You have to divide the triangular ligament. It depends a little bit on how much blood the patient has lost and how comfortable you feel going after it. Packing is certainly an available option if you know you're going to get help. And there's no shame in calling for help, obviously. I think in the setting you've described, excuse me, a stab wound, venous hemorrhage, I probably would pack it and wait for help to come.
Can we redo the bowel until we're waiting for help?
Yeah, if the bowel's been injured, yes, you can certainly fix the bowel. If it's a stab wound and there doesn't appear to be a lot of necrotic tissue, you can probably just repair it primarily. And hopefully there's not been a lot of contamination, but that does not require, at least in current thinking, as long as the patient's not in shock, you don't have to do anything like a diverting stoma or anything else like that. You can fix the bowel. If the patient's hypotensive or cold or anything else like that, then it becomes a little more of an issue. You might have to do a temporary stoma. But thinking about colon injuries with penetrating wounds has evolved a lot in the last 30 years, where a primary stab wound like you described would probably be amenable to just getting it repaired, assuming you got good tissue and assuming the patient is stable. If those assumptions aren't valid, then you may have to do a temporary, resect the bowel and do a temporary stoma.
Thank you.
Next question from Alexander Boyarsky.
Good evening. Thank you for the lecture. What indications for hand assistant laparoscopic surgery do you consider as part of learning curve for more complicated procedures?
Did you say hand assisted?
Yes.
Well, I'll be honest with you, Alexander. I don't think I ever did an hand assisted. I'm an older, I know I look like I'm a young, healthy guy, but I'm an old guy, right? So I've only done laparoscopic gallbladder surgery and some appendices. I thought that the hand port for laparoscopy was an admission of failure. If you have to put your hand in, why don't you just open the abdomen and do it the way it was originally done? So a lot of my colleagues, my younger colleagues, don't agree with that, but I often think to myself, the one thing you lose with laparoscopy is your fingers. You can't feel what it is you're trying to get at, and that's a sense that's very important for surgeons. So I guess I can't answer the question, to be honest with you. I don't think I would not probably do that. I know a lot of my colleagues will, for instance, if they're doing a right colon laparoscopically, they'll make an incision just enough to get the hand port in, but also in some older patients, the right colon isn't very attached. The peritoneal attachments aren't there. You can actually mobilize the colon up into that incision, and you don't even need it at all. Dr. Dzmailov's mentor, Dr. Melnichuk, her partner, Dr. Goldberg, who I know you've met, Ali, he likes that idea. To me, the hand port is, well, I guess I said it. I don't think it's a great idea.
Thank you.
But I'm an old guy. You got to understand that.
Okay, thank you very much, Dr. Kenney. So it seems like we do not have any more questions. And thank you very much for this lecture. And thank you all participants for joining us today. And I wish you safe and good evening in Ukraine. And thank you. Yeah, Dr. Kenney.
One more thing, I want you all to know we should congratulate Ali because he's going to be starting his residency in surgery at the Brigham Women's Hospital on July 1st. So congratulations for you.
Thank you very much, Dr. Kenney, for all support. And I'm looking forward to learning from you clinically. Thank you very much.
All right. Very good. Good luck to you all.
Thank you. Thank you.
Peace.
Thank you.
Thank you. Bye-bye.
Kenney, bye.
Bye-bye.